Hello and welcome to DTV. In 2016, there were over 1,631 reported deaths from drug overdose in Tennessee, up 12% from 2015, with 224 of those deaths happening in Knox County. Knox County saw its rate of drug overdose deaths jump 31% over the same 2015 numbers. All this is happening within the context of what the Center for Disease Control has called opioid addiction epidemic, and which has proven to be one of the most deadly drug trends in modern U.S. history. I'm Michael Davis, and I'll be your host for today's DTV episode that addresses addiction and drug treatment in the Knoxville area, an issue that has affected countless lives and continues to be a serious concern for East Tennesseans. To discuss these issues with us today are our panelists, Metropolitan Drug Council Executive Director Karen Pershing and Cherokee Health System's Director of Addiction Medicine, Dr. Mark McGrail. Karen and Mark, thank you very much for being here with us today. Welcome to DTV, and thank you again for spending your time with us today.
Thank you.
Thank you.
Can you both please share with us a little bit about how you've come to work in the field of drug treatment and your roles in your respective organizations? Karen?
Well, I've actually been with the Metro Drug Coalition now for 7 years as the executive director, and we're actually a substance abuse prevention organization. So we work really as an anti-drug coalition. So we bring together diverse stakeholders to assess what's going on at the community level and try to address the community needs. But we're really trying to get in front of the issues to try to prevent the issues from getting worse. So we work with treatment, but also work with law enforcement, medical professionals, a lot of different agencies and organizations in our community. So we're not treatment experts per se, but we do work in collaboration with our treatment professionals.
Okay. And Mark?
I came in to addiction treatment after a long career as a family physician, so I got to see a lot of the effects of mental illness and addiction from that side of medicine, and took the opportunity to grow my personal interest in behavioral health by completing a fellowship in behavioral medicine right here at the University of Tennessee Medical Center. It just so happened that my first clinical experience as a fellow was with the addiction program at Cherokee, and just what kind of that proverbial found my calling, if you will, and then was able to focus the remainder of my fellowship into a lot of addiction training, and then was able to come back after being a fellow and join Cherokee on the staff and help expand on their addiction programs.
Okay, great. So this has been a developing interest,
Absolutely.
more or less, for you.
Yes.
Okay. Well, it seems to me that an interesting question that I would pose to both of you would be asking, what do you most wish that you could convey to the public about drug addiction and its treatment or its prevention?
Well, as far as I'm concerned, when it comes to prevention, it is something that is preventable. And I think many times that is totally missed, and we tend to want to clean up the problem after it happens instead of focusing on preventing it before it occurs. And I think that's an important thing that everyone needs to keep in mind, is that you can prevent addiction. And it's much less costly to all of us to prevent it before it starts. And it just takes effort on the front end to really understand what you can do to prevent it. And it's really everybody's responsibility to learn what you can do to prevent addiction. And it starts at a very young age. And all of us as adults can do things as we're raising our children to help plant those seeds to prevent addiction later on in life with adults.
Right. Okay. And Dr. McGrail?
Yeah, I absolutely echo Karen's comments. Like with any great public health emergency, prevention is always the best way to go if you can. But what I would really like for people to appreciate who don't know a lot about addiction is that it is a disease. For so long, like with many, particularly mental health problems, that they're often looked at as a moral failing or a character defect. That's not the case with addiction. We know the science. We've now known it for years. It is a disease. It doesn't spare any socioeconomic group. In our program, we have people in their early 20s to people in their mid to late 60s, grandparents to children. It spares nobody. Homeless to business people to healthcare workers.
Right.
There is no boundary for this disease. And if we could appreciate that and then attack it like we do other public health diseases like measles and smallpox and diabetes and heart disease, maybe we would, can make a dent in this epidemic.
You mentioned some of those scientific aspects, biological, chemical factors of addiction. How do they vary from drug to drug and person to person that you wish that people understood more about treatment and prevention?
I think from the disease model, we know kind of broadly, regardless of what the drug of addiction is, that it's multifactorial, that there's roughly a 50% genetic predisposition to it. We often see that as we bring patients into our program. They have parents and brothers and sisters who also suffered from addiction. But that's only about half. So the other half, like Karen has mentioned, there's opportunities for prevention. Right. There's the social environment, there's access to the drug, there's exposure to the drugs. If we can intervene on some of those things that are modifiable, you can't change somebody's genetics, but you can help modify the environment and the exposure. And then if they do develop a disease, then we can, implement a treatment.
Right. And Karen, I believe that you mentioned that the prevention, both of you actually mentioned that with prevention, it's a much easier thing to prevent than to put the pieces back together, so to speak. Do you think that there's anything within the culture of the Knoxville area or Tennessee or the United States in general that contributes to that, or and how might we go about most effectively changing that?
Well, I think when you look at the culture of the Appalachian region of the country, I think you can go back in terms of addiction and addictive disease. You can go back to bootlegging. We have a culture of moonshining, bootlegging that goes back for multiple generations. Again, the drugs have changed, and the availability of the different drugs have changed over time. So right now it may be opioids, heroin, fentanyl, those types of things. Again, that goes back to the environment and the availability of certain drugs at different times in the history of the course of the United States and in certain parts of the country. But again, you look at those genetic predispositions like Mark talked about, and those again go on for multiple generations. So again, you've got those cultural factors that we see that are more prevalent in the Appalachian region of the United States. There's some research out there that also talks about poverty and how poverty drives some of this as well, because there's economic factors that are related to some of these behaviors and some of the addiction. It becomes a business for some folks.
Right.
Like the bootlegging did. It became a family business to manufacture moonshine, and same thing with the pills. People were going to pill mills and they were getting these pills, selling part of them, using part of them.
Right. And
it became a way for those families to take care of themselves and to survive. So again, it's multifactorial, like Mark mentioned, and so it's very it's like an onion, so you can't point to one particular thing and say, if we work on this, we're going to solve all the problems. You've got to really peel back that onion and look at the multifactorials and attack the problem from very different angles.
Right. So, Mark, what would you say you've personally seen, or that the drug treatment field knows about treating those layers and how to take a multifaceted approach to treatment about this if we know that it's a multifaceted problem?
Right. I think, again, if you start to look at what are the risk factors for addiction, we know that we, obviously can't change a person's genetics, but what we can do in part of the prevention angle is to identify those who are at risk because of their genetics. You were asking Karen about some of the cultural and those aspects of our country and what has maybe led to contributed to this epidemic. Clearly if 20 years ago every time I did a well child exam, the family was open and said, yes, I'm an alcoholic, the
Right.
parent or the grandparent, or we knew that history, okay, now we have an opportunity to intervene with that child before 20 years later they're addicted to something.
Right.
So, if we could, kind of at least address that part of it from a prevention standpoint on that multifactorial approach. And then the other part is that other half of what leads someone to be addicted. And that, for example, at our program at Cherokee, we recognize that, even as a physician who can prescribe medicines, I like to think I have a relatively small part in addressing somebody's, overall treatment. There's so much to addressing their living situation, their economic opportunities, family situations, food security. Oftentimes if someone doesn't have money for food, they'll, they're in other situations that just lead them down a path that ends with addiction.
Right.
So, a lot to address.
Definitely. And Karen, is there anything specifically that the MDC is putting into place to address this with a multifaceted approach?
Well, one of the things that there's a lot of research coming out now too about adverse childhood experiences. And so we're really integrating now into our prevention programming information about adverse childhood experiences and things that happen to kids as they're growing up, and the relationship to that early childhood trauma, and the fact that the relationship and the strong association to that trauma and the potential for substance use disorders as an adult later on in life. And so by mitigating that trauma and building resiliency in that child when those traumas occur and helping them work through those traumas, we can hopefully prevent some of those substance use disorders later on too. And I think in the past we've always said kids are resilient, yes, they go through things, but they'll be fine. But we're not seeing it, by covering that up or not really dealing with it appropriately, things like sexual abuse that occurred with a child, or physical abuse or neglect, the death of a loved one. All of those things are traumatic for children. And again, if they're dealt with appropriately and at the time they happen, they can build resiliency in kids if they've got a caring adult that can help them work through that. But if they're covered up and they're not dealt with appropriately, that child carries it around with them and may feel shame, may feel guilt over those experiences, and may what we call self-medicate as they get older to try to deal with that trauma and that experience that happened to them. So again, there's a lot of research and there's a lot of evidence to really say that we as adults really need to pay attention to those things when they happen to our kids and really try to mitigate those experiences.
Right. And it seems that would be obvious, yet this kind of common misperception that if it's out of sight and out of mind with a kid, they will just adjust and start out magically at the age of 18 with some kind of a clean slate with whatever childhood trauma washed away by aging simply. But what sort of evidence, I guess, out there tells us that is there any evidence out there, Mark, that we would know, that we can look at that tells us that this is a misperception, that we should be concentrating on our youth and addressing these things through whatever methods, be it therapy or other behavioral treatment approaches, to head these problems off that we know exist just due to the correlation with trauma? Is there anything, is this, I guess, is the psychological field, the drug treatment field, awakening to this, and how do we get that perception across to the public?
Yeah, I think there's a lot of data that shows, and our own program is very consistent with this. More than 90% of the patients who come into the program we have started using in generally their early teens. Often, the most common use is, people are familiar with the term gateway drug.
Right.
So it was there's usually gateway drugs, typically alcohol and marijuana, very
Right.
frequently the first things used, but those again, for 90+% of our folks are starting 12, 13 years old. I've had one patient who was exposed at the age of 4. But like any medical problem, if we don't ask, we don't know. And I think that's one of the things that probably one of the better things to come out of this is that we're recognizing, that there's a problem. If we start to ask that, people are getting more accustomed to being asked. Every patient who walks into Cherokee gets asked about substance use, period. Every patient. So it's not, you look like you might be using. We're going to ask you, but not you. Everybody gets asked. If we have universal screening, we'll identify the people who are at risk. And that needs to really start in late childhood, adolescence.
Right.
So we can intervene early.
Yeah. And that brings up the question about stigma with substance abuse and addiction. Is the perception of people who are addicted or use a substance, how does it affect people's readiness for treatment and the way that people look at others, even though, like we know from most studies, most data, that almost everyone touches on some sort of substance use or becomes affected by it at some point in their lives?
Well, I think stigma is a huge issue because we see on average people are using 10 to 12 years before they ever seek help. And so they're suffering in silence for many, many years before they're able to come forward and actually get help. And that says a lot right there, because for fear, fear for, how their families are going to perceive them, how their friends are going to, their church, are they going to lose their jobs? So we have got to really work on that as a society if people are truly going to get help. And get help early on in the disease process, because we know, and Mark can attest to this, the earlier you can intercept that disease process, the better off people are going to be.
Right.
And the more likely they are going to be able to maintain a life of stable recovery. And so people who, the longer they use, the more difficult it's going to be for them. And again, they're not going to come forward if they feel shame and feel like the world is going to be against them for the rest of their lives. And unfortunately, that's where we are right now. Just the terminology we use, calling people addicts, calling people alcoholics, and they're people with substance use disorders. So that's part of what we're trying to do at Metro Drug Coalition, is really getting people to think about the language we use.
Right.
Even this clean and dirty thing. When you go in for a drug screening, when you go in for any other laboratory testing, you're positive or negative.
Yes.
Why do we say for a drug screening, you're clean or you're dirty? You're not clean or you're dirty. You have a positive or negative drug screen.
Right.
So again, just even things like that, if we're ever going to decrease stigma, we have got to start using different language.
Right. Yeah, our thoughts definitely come out in our language,
Yes.
or our perceptions come out in our language there. Very interesting point there. Along with the period of time before someone seeks treatment for any sort of addiction or dependency issues, how is that compounded with mental health issues that we know so often go along with those issues?
Right. When we get folks, as we've looked back at our data, we have an instance of roughly 80% of the patients who come in identify with a separate mental health disorder. Some of it becomes the chicken or the egg.
Right.
Did the substance use lead to the depression or the anxiety? Did the depression lead to the substance use, to self-medicate a behavioral health condition? But as far as I'm concerned, though, it doesn't matter.
Right.
If you're using and you're depressed, we need to treat both. We need to address both of those things. And again, if there's hopefully a good thing to come out of this will be recognition of, that the mental health disorders, the substance use disorders, they're real diseases. They deserve to be, treated as such, and they're not something to keep hidden, as you indicated,
Right.
And not to talk about.
Yeah. So this leads us to what do we do about all of this? I think it's always been my perception that the treatment providers, the people that work for prevention on the ground, they're up on their research, they do a good job. It's sometimes the policies, sometimes the other components of the system that aren't educated enough to affect policies and laws that even enable the treatment providers and the people working in prevention to do what would be most effective. So what do you feel like is the main motivator or chief underlying concern for addiction and drug policy in our area?
Well, I think one of the things that is really kind of perpetuates stigma around mental health and substance use disorders is the fact that we carve it out of the mainstream healthcare system, the way we even pay for
Right.
things now. So, you go to the doctor and, they're going to treat your physical health. But then if you have a mental health issue, you're going to have to go over here.
Right.
Your benefits are even separate, and how that works. So your co-payment for your medical doctor visit may be $35, but you go over here for your mental health, it may be a $65 co-payment. And you may have a limited number of visits over here, whereas you can go to your medical visits as many as you want. Even though there was a Mental Health Parity Act at the federal level that passed in 2008, there still really isn't parity yet in terms of how that plays out. And so, there's still some work that we need to do. Even in Tennessee, our TennCare patients, there's separate mental health benefits from their medical as well, so they have to go to separate providers for all of those, which again, that kind of increases stigma. So, I have to go over here, people know if I'm going over here I've got a mental health issue.
Right.
Whereas what's beautiful about Cherokee Health Systems is they have a totally integrated practice. So if you walk in their door, no one knows if you're coming in for addiction treatment, mental health, or a regular healthcare service. And so, it's great that there's a lot of conversations happening at the federal level about truly integrating healthcare services.
Yeah.
Because I think until we get there, we're going to continue to have a lot of stigmatic language
Right.
and a lot of difficulty decreasing that. And I think Cherokee definitely has a model that I'd like to see more and more of, and more of that integrated medicine concept, and not so much of this carving this here and there and everywhere, running all around trying to get your comprehensive health care needs being met, when we should really be looking at individuals holistically, and your mental health and substance use disorders are just part of your everyday health care.
Right.
So until we get there, I think, it's going to be difficult for folks with mental health and substance use disorders.
Yeah. Would either of you have any specific policy suggestions for the people that are in power, that make those decisions, that make policy and law, for what could be done to improve addiction prevention and treatment?
Well, I think, again, Karen can comment more on the prevention piece, but I think from the treatment side, I think anything that promotes the availability of treatment, the knowledge of providers, systems that put in place training, particularly primary care. Even with our psychiatry colleagues, the majority of all mental health occurs in the regular primary care office. As a family medicine resident in the 90s, I had, in a 3-year residency, I had 1 week of exposure to substance use disorders. And that was as an observer in a program.
Right.
Yet if you look at the data, anywhere from 1 to 15 to 1 in 20 patients walking into a primary care office has a substance use issue. And wholly untrained, really, on the provider side to adequately care for that. Hopefully if we can put in, again, things in place to promote the training, provide those exposures, funding for things like fellowships to have providers get some advanced training to support our most vulnerable populations.
Okay.
Be very useful.
Right. Karen, anything to add on the policy side of that?
Well, of course, prevention, primary substance abuse prevention is grossly underfunded. I can just say we're usually, for example, we get a substance abuse prevention and treatment block grant that comes into the state from the federal government. 80% of the block grant actually goes to fund treatment programs in our state, and 20% of that goes to prevention. So again, it's very lopsided, and of course treatment does cost more money than prevention, but at the same time it's very difficult to scale up prevention with the amount of resources we have, and we know prevention works.
Right.
It's just having the resources to scale up what we have available to us.
Okay. I think we probably have time for just one more question, and I'd like to bring it back down very local. Do you have any specific recommendations that you could suggest to the Knoxville City Council or the Knox County Commission on how to best address, with the resources that we have, local addiction and drug abuse issues?
Well, I think some of that is happening now. The Behavioral Health Urgent Care Center, by diverting people from jail. We don't need to be putting people in jail that have mental health or substance use issues. I think having a place for them to go and be assessed and be connected with local resources where they can actually get help is a good first step. I think also any other pre-diversion programs that we can come up with, because once people get criminal records, it's very hard for them to gain employment once they do get the help they need. So anything that we can do pre-diversion. But I also think too that we need to look at making sure that we have adequate treatment for women, especially residential treatment for women who are pregnant, women who have children. We have dire need for that.
And Mari, quickly, anything to add to that?
I echo all of her comments. The only thing I would add is, safe housing.
Right.
A lot of our patients at Cherokee, we take care of a lot of homeless patients. I don't care how well you're doing in treatment, if you go back out on the street and use is all around you, you're exposed to it 24/7. It's hard to recover.
Far too difficult to do it without that solid base under you. Okay. Well, Karen and Mark, this is an extremely important topic about which we could go on to discuss just volumes, but unfortunately we've come to the end of our time for today. Hopefully you'll be willing to join us at DTV here in the future to discuss more of these challenges to the Knox area, but thank you so much for being here with us today.
Thank you.
Thank you for having us.
And of course, thank you to our viewers for giving us your time. Thanks again to our guests, Karen Pershing of the Metro Drug Council and Dr. Mark McGrail, Cherokee Health Systems. I'm Michael Davis, and this has been DTV.